Edward Zerm. Thereafter, the first eye bank was established in the year 1944, the eye bank for sight restoration in US, and in India it was 1945. Now, if you look into the evolution of keratoplasty, it's almost like a modern-day epic. So we had, in the prehistoric times, we had lamellar keratoplasty, and then in 1905, we had penetrating keratoplasty picked up. And then from the late 1990s, we had a radical awakening of lamellar keratoplasty techniques again. Eye banks, when they evolved, they were institutions responsible for collecting, processing, and distributing corneas for transplantation in a timely manner for the needy patients. Now, after the first transplantation by Zerm in 1905, only a few improvements were made in the next 100 years, which involved only some transition in microscope sutures, antibiotics, steroid regimens, but not much in the surgical techniques. The late 1990s saw an explosion in more selective corneal transplantation techniques, especially so in endothelial keratoplasty. In 1998, Gerrit Mellis proposed the posterior lamellar keratoplasty, which was involving selectively removing the diseased endothelium and replacing with the posterior stroma and endothelium. Terry called it DLEC and popularized it in US. Thereafter, in 2005, it was Price who proposed DSEC by just removing the Descemet's membrane, followed by transplant of the posterior lamellar graft. Gorowa introduced the use of microkeratome, and thereafter the technique became very automated. Now this concept was a real revolution because it moved the pre-cut surgeries to the eye bank itself. So here the manual dissection was replaced by the automated technique. Mellis in 2006 proposed a Descemet's membrane endothelial transplant, and it's been way forward now with the endothelial keratoplasty. Nancy Joyce in 2000 proposed that the human corneal endothelial cells can proliferate ex vivo and replicate under specific situations. Now, in the year 2018, Kinoshita proposed, and he proved that there's successful outcome of endothelial cell therapy in management of corneal edema, and this was the work published in 2018 in NEJM. So if you look at the eye banking activities, these have kept pace with the changing practice patterns and newer techniques of corneal transplantation. Now, the present role of eye banks is not just collecting the corneas, but the roles have expanded and responsibilities are way beyond harvesting the corneas. The donor cornea evaluation, which was earlier done by the clinicians, is now moved into technician-based cornea evaluation. This indeed was initially met with a lot of trepidation. There was an initial reluctancy and apprehensions, but it was an important decision in modern-day eye banking as it helped in standardizing the donor cornea evaluation and streamlining the process of cornea evaluation tissues and eliminating the wastage. Year 2006, because of automated DSEC, the beginning of corneal surgery happened in the eye bank for the first time, and pre-cut tissue moved to the eye banks. Most of the posterior lamellar graft preparations are done in many of the eye banks in the eye bank itself and not by the surgeons. This again had a lot of apprehension, but this was a natural consequence of the increased popularity of endothelial keratoplasty and relieving the surgeons of the pre-cut step, which could be eliminated in the OR itself. This made the surgery very predictable for the surgeons as well as eliminating tissue loss, which could happen on the day of surgery. Going way forward, the pre-prepared tissue for DSEC is available in most eye banks, and DMEC also is adopted. The pre-cut, pre-prepared tissue for DMEC is also available in many eye banks in US. This is yet to be popular in India, but hopefully we should look forward to it in the future. Now, going one step further, not just pre-prepared cornea, but the preloaded tissue for DMEC is also available in many of the eye banks in US. And this has, again, reduced surgical time. You just have to inject the tissue because it's provided in a modified Jones tube or an injector or any other substitute. So it's reduced the surgical time even further, and this is adopted in the eye banks. Amnion graft, as Manisha mentioned, is an activity which is meant for many of the eye banks, and many eye banks have adopted this technique and distributing the amniotic membrane. From the eyeballs, the glaucoma shunt surgeries require a patch graft or a corneal tissue, and this is again a routine activity for many of the eye banks. Now, the corneal tissue which we use for transplant carries a certain risk of rejection and also risk of infection. Now, there's a strategy of gamma irradiating the corneas, and this is more known to make the cornea more sterile, stiffer, and lesser antigenic. Now, this is adopted in some eye banks in the US, and this tissue is used for the anterior lamellar keratoplasty and supposedly seems to have a lesser rejection rate. This, again, is technology which can be explored in future. In US, it is available from the vision graft. Now, there's a lot of progress which has been made in the regenerative medicine. So, in the future, it may just so happen that many of the delivery of the translational research technology and the cell-based therapy, the eye bank will become the contact point for these therapies. Many of these are conceptualized and many of these are already implemented in a limited way. There is bioengineered cornea or artificial cornea, cornea equivalents or scaffolds used for corneal diseases. And these are made from the recombinant human collagen and synthetic phosphocollagen polymer. This is from the May Griffith group, and it is proposed that artificial cornea can be used for anterior lamellar keratoplasty. Eye banks may get involved with this in the future. We have the corneal lenticule, which are extracting during the SMILE procedure. Now, there's a possibility of correcting hyperopia in keratoconus patients. Of course, this will require some bit of decellularization after the tissue is retrieved, but this is again one strategy which may be adopted in future by the eye banks. We already have the culturing of the epithelial cells for ocular surface disorders for bilateral corneal conditions. Similarly, the cultured endothelial cells and the engineered endothelial cells, this could be again a therapy for the endothelial diseases in future. It is already proved by Kinoshita, and most likely the cultured cells may be available from the eye bank for many of the endothelial pathologies. Now, in a traditional manner, this kind of scar will require a transplant or anterior lamellar keratoplasty or at least some kind of corneal intervention. But there's a possibility of having stromal or mesenchymal stem cells which can be used for treating these scars. And there is work going on, and in future possibility of stromal cells being available from the eye bank for treating these kind of scars is also possible. Now, what about other specialties? What about the glaucoma specialists and the retinal surgeons? Now, there's some work from Japan which shows that the trabecular meshwork has progenitor cells for treating glaucoma. Now, there's also an interest if we can preserve the retinal layers, is it possible to treat the retinal disorders? Most likely time will tell, but this is something which has been explored in the research community. Now, just as we have component corneal surgery, we may start having component ocular surgeries. Again, this is all predicting the future. We don't know how much we can go from this stage. But most likely, looks like the eye banks, they will not be just catering to the cornea, but maybe in future we may have to call them not just eye banks for providing corneal tissue, but ocular tissue, cell culture, and engineering eye banks, because there's lots more which is going to happen in the future. Thank you.
Thank you very much for enlightening with new concept. Now, may I call upon Professor Dr. Ritu Arora.